So the next thing we're going to talk about is triple negative breast cancer, and I think that it's a tough kind of thing because of the way we defined it. I think docs define triple negative breast cancer as all cancers that are not ER positive and not HER2 positive. You know, and the problem is that the test couldn't have worked. So 5% of the time I found their patients are probably HER2 positive, you didn't know it. And you know, in my practice, you know what I make you guys do. You know, when it comes in with triple negative breast cancer, if there's even a hint that they're HER2 positive, I make you redo it. You know, and it's a pain in the butt because you got to go get the block and the patient's waiting to figure out what happens. I mean, I know, I don't know how you guys feel about that, but I know that that's what happens in our practice. So the thing is, you know, that's one thing, is defining it. And the problem is that once you define it, you know, there are multiple different subtypes of it. You know, there's patients who are BRCA positive, and we see them. You know, that's one subtype of triple negative breast cancer. You know, there's triple negative breast cancer that appears to respond to immunotherapy. You know, there's a triple negative breast cancer that may give people anti-androgens. You know, it's like ER positive breast cancer, but for the AR. You know, so and there's all these subtypes, and it's hard to lump everything together. But right now, the only thing we do is chemo. As people come in, most of them, as you know, get neoadjuvant chemotherapy. You know, the bigger thing with triple negative breast cancer is it's got such a bad rep. I mean, you know this. I mean, how do you handle, people must talk to you, and they must go, oh my God, I have triple negative breast cancer. I read this thing on the internet, I'm done. I mean, I'm gonna die in a year, you know, and how do we handle that?
Well, when we do our teaching and we tell them about the drugs and how they work, we tell them that we're going to continue along this path with these drugs. We're going to restage them. We're going to follow them and make changes as necessary. Yeah. I've had patients who have been very concerned because then they felt they had no options. That they felt because they were negative, they didn't have the options.
Right. That's a big one. I can't get tamoxifen. I can't get Herceptin. Yeah. You know, I'm done.
And I always try to stop that right there, because there's so many things, again, just knowing how much research we're involved in, I believe that there's so many things on the horizon that if we're treating you and we're following you, that perhaps something that may not be available today might be available in a couple weeks or a couple months.
A couple months or years, yeah.
But we're there to again, just encourage them and know that we're doing the best we can with what we have available, and that there's always more that's being worked on.
That's an important thing. Yeah. You know, I think it's really important, and no matter whether you have early stage triple negative or late stage triple negative that's relapsed, there's always something to do. And I think that's really important for you guys to convey, for us to convey. Yeah. You know, it's easy. It's very easy as a doctor.
I have told patients
to throw up your hands and say, all right, go in a hospice. There's nothing else we can do. There's always something you can try.
But I've never, ever heard you say that. I'm done. I've got nothing left. You always have something.
Well, but again, I think, and you know, sometimes that's not good on the other end, as you know, because the problem is that, you know, sometimes you don't want to torture people, and I tell that to them. I mean, as you know, we get to a point where no matter what we do, unfortunately, you know, it's just not working. And, you know, at some point, people usually tell me, and I let people give me the lead that I'm done. You know, I just want to live whatever time I have left and be comfortable. And, you know, hopefully, we don't want that to happen, but unfortunately with triple negative, it happens more than we'd like. But on the other hand, there's always something to do. And even, you want to know the truth, even when you're in hospice or something to do, you can always help someone have less pain, less nausea, less side effects, be comfortable. And that's the key. I think people, when they give up all hope of anything and they just feel abandoned, I think that's the thing I don't like. As you know that, as you've working for me for a long time, you know that's what I don't like more than anything.
Well, I've had patients tell me that one of the best things that you said to them is, if you still want to fight, I'll fight with you.
Correct.
And I've had patients tell me that, and I've also had patients come right out and have the conversations with me, perhaps not you.
Right, they have it with you, they never have it with me. They don't want to tell me.
But part of the job of the nurse is to let them know the resources that are available, palliative care, you know, how we can make them as comfortable as possible and enjoy the time that they
And we're not gonna let them down. I think people just want to know that someone is there. We may not have a ton of things to do at some point, hopefully we do, but sometimes we don't, but you're there. I think it's key.